leukocyte changes. And this leukocyte changes is also leukocyte extravasation. And what's leukocyte extravasation? So extravasation means leaving the blood vessel. So this is the process by which leukocytes move from the bloodstream into the inflamed tissue. And it mainly occurs in the post-capillary venous, that same location we mentioned earlier. So neutrophils are the primary leukocytes in acute inflammation, and that extravasation occurs in the post-capillary venous. So again, if you look at this picture, so here we can see our blood vessel, and inside the blood, lining the blood vessel, we have the what? We have the endothelial cells that are lining those blood vessels. So we have our endothelial cells. And let's say this is the site of the tissue, and maybe at the site of the tissue, maybe there is a bacteria there, or there is what? There's an injury there. So, but for the purpose of we can use what? We can use bacteria. So what's going to be the first step in order to move the leukocytes into the site of the tissue? Because the leukocyte is inside the blood vessel, and our goal is to move our leukocytes, our neutrophil, from here and move it to the site of the injury. So the first step there is going to be margination. So they have to move to the margin. So this white blood cell is going to move to the margin. So margination is the process where the leukocyte move from the center of the blood vessel towards the endothelial lining during acute inflammation. And there are two forms of neutrophil that we have. So they are divided into two. So we have what we call the circulating neutrophil. So those are the neutrophil that are circulating. They are not bound to any adhesion molecule. And then we also have what we call the marginating pool. So those marginating pool of neutrophil, those are the neutrophil that they are attached to the adhesion molecule. So when you look at them, they are bound to the what? Adhesion molecule. So those one we call them what? We call them marginating. And every time you do a complete blood count, what we normally count is the circulating pool of neutrophils. So that's what we normally count. And that's why if somebody is taking medication like corticosteroid, so like steroid, so this corticosteroid normally inhibits adhesion molecule. So by inhibiting the adhesion molecule, that means this white blood cell, instead of it being marginating, is going to become what? Circulating. And then remember, like I mentioned earlier, anytime you do complete blood counts, what we are counting is the circulating neutrophil. So that's why if somebody is on corticosteroid, they're going to have what? Neutrophilia. So their white blood cell, they're going to have increase in white blood cell. And the reason why their white blood cell is increased, is because this bound or marginating neutrophil has become what? Circulating neutrophil. And who can also remind us what's also the other effect of corticosteroid on the blood cell? Very good. So if somebody is on corticosteroid, what's going to happen to eosinophil? Very good. Eosinophil will be what? Decrease because of apoptosis and sequestration of the eosinophil in the lymph node. What about the lymphocyte? Very good. Lymphocyte is also going to be what? Decrease because of apoptosis of the lymphocyte. So that means if somebody is taking corticosteroid, eosinophil is going to be decreased because of increased sequestration and apoptosis, and lymphocytes will be decreased because of increased apoptosis. But neutrophil is going to be increased because of demargination. So those neutrophils, instead of them being at the margin, they are being demarginated, and now they become what? Circulating pool. So moving on. So now what's going to happen in this case? So in acute inflammation, so there's going to be release of what? Acute phase cytokine. Remember, we mentioned this earlier in the past. So this acute phase cytokine, particularly interleukin-6, is going to stimulate the liver to make acute phase protein. And one of those acute phase protein is fibrinogen. So this fibrinogen now is going to be coating the red blood cell. So once we have our red blood cell, so we have our red blood cell inside the blood vessel. So those fibrinogen now are going to be coating the what? They're going to be coating the red blood cell. And as they are coating the red blood cell, that's going to remove the negative charge on those red blood cells. And then once you remove the negative charge on those red blood cells, or once you decrease the negative charge on those red blood cells, that will allow those red blood cells to what? Aggregate together. And then once they aggregate together, we call them what? Like a rulose formation. And remember, the more aggregation, the more inflammation you have, the higher the interleukin-6, the higher the fibrinogen, the more red blood cell is going to aggregate. And then remember, as they aggregate together, like we mentioned in the previous lecture, that will increase their density. So that will increase their density. And then when you put them inside a test tube, a vertical test tube like a pipette, when you put them there, they're going to what? They're going to fall faster. And what do we call that? Very good. Erythrocyte sedimentation rate. So the longer the inflammation, the more likely they're going to fall what? Faster. So because of this rulose formation, then that will now push the white blood cell, right, to the periphery of the blood vessel. So that will push them out. So as you can see there, so the rulose mechanically forces the neutrophil out of the central acid stream and push them to the peripheral. and that's what we call margination, guys, margination. And remember, we mentioned earlier, because as you lose plasma, what happened? Remember, we said that there's stasis of blood, and that also facilitates what? Margination. So the next step there is going to be rolling. So now that the neutrophil has marginated, so now they need to roll to the wall of the blood vessel. So for them to roll to the wall of the blood vessel, what do we need? So like we said, rolling is the process where neutrophils slowly roll along the endothelial surface instead of flowing freely in the bloodstream. And then for rolling to take place, so what do we need? So we need selectin. So they are selectin-mediated interaction. So rolling is primarily mediated by selectins on the endothelial cells. So we have E-selectin, P-selectin. So this E-selectin is on the endothelial cells. Both of them, both E-selectin and P-selectin, both of them are on the endothelial cell. And this E-selectin is induced by our acute phase cytokine. Remember, we saw that earlier, that those acute phase cytokine, they induce the selectin. And this P-selectin is stored in Weber palate body. And of course, it's rapidly mobilized out of them and released, ready to be used. And what are they going to do? So this P and E-selectin that's on the endothelial cell, they're going to bind to cilia Lewis on neutrophil. So on neutrophil, we have what? We have our cilia Lewis, and that's what they're going to what? Bind to. And then once they bind to it, that's what allowed them to what? To roll. Very good. And then the other thing we also have is also the glycan 1, which and a CD34. And then both of them are adhesion molecules on the endothelial cell that function as ligands for L-selectin on the leukocyte. So this one are going to be binding to the L-selectin on the leukocyte. And of course, if there's a problem with this guy, that will lead to what? That will lead to impaired neutrophil recruitment. And that's why we have to do a chemical correlation here. So there's a disease whereby if you have problem with your S. Lewis, guys, if the S. Lewis is affected, if there's a deficiency of it, so that means that will lead to defect or problem with what? Rolling. And as we mentioned, this S. Lewis is the ligand for our E-selectin, right? So that's what the E-selectin is going to bind to. So neutrophil cannot roll properly due to defective of S. Lewis, leading to recurrent infection. So remember, in leukocyte adhesion deficiency type 2, right, is due to the deficiency of S. Lewis. And the way I remember is S like a secondary or like a second. So that's why I know that that's affected in leukocyte adhesion deficiency type 2. So now let's say no problem. Let's say rolling was able to occur. So it's able to roll. So our white blood cell is able to roll to the wall of the blood vessel. So now after rolling, what's going to be the next step? So now that they are the periphery, so the next step is going to be tight binding. So they have to bind to the wall. So the next step is going to be tight binding. So neutrophil adhesion to endothelium. So what's the mechanism? So neutrophil is going to express integrins. So for here, we need what? Integrins. So neutrophil express integrins on their surface. So we have the LFA1, which is lymphocyte function associated antigen 1. And the CD marker for this one is CD11A and CD18. And we also have the MAC1, which is macrophage 1 antigen. And the CD marker for it is also CD11B. So instead of 11A, this one is 11B and CD18. And then what we have on the endothelial cell, so on the neutrophil, that's what we have on the neutrophil. What about on the endothelial cell? So on the endothelial cell, we have our ICAM1 and BCAM1. So ICAM1 is intercellular adhesion molecule 1, and the CD marker for that is CD54. And on the VCAM1, that's vascular cell adhesion molecule 1, and the CD marker for that is CD106. And as we mentioned earlier, these are all regulated by the help of what? Our acute phase cytokines, so interleukin 1 and TNF-α. And this will allow them to be able to what? Adherent to the wall, what we call tight binding. So neutrophils stop rolling and adherent tightly, and it's going to now prepare for what? Migration, which is what we call diapedesis. So what about if somebody have problem with their integrin, which is what we call leukocyte adhesion deficiency type 1. So they have to be type 1. So the way I remember, like integrin looks like 1. So type 1. Remember, S. Lewis is going to be what? Type 2. But integrin is type 1. So defect in beta 2 integrin, whereby the CD18 integrin deficiency. And this leads to what? So what are the problems we're going to see? So that means the neutrophil cannot bind to the wall. It can't adhere to the wall. So that means we're not going to have any marginating. There will be no marginating what? If we go back to our diagram, there will be no marginating neutrophil. So that means all our neutrophil are going to be what? Circulating. So that's why those patients are going to have what? Very good neutrophilia. So they're going to have neutrophilia. And then we can't get neutrophil to the site of where the bacteria is, because the neutrophil will not be able to leave the blood vessel to go to where the bacteria is. So that means these patients are going to be having what? Recurrent infection. And then when you look at the site of the infection, what's going to happen? You're not going to see inflammation there. So now to be absence of what? Pus, because you can't get neutrophil to where the infection or bacteria is. So what are the clinical clues? So recurrent bacterial infection, delay in umbilical cord separation. Because when you cut the umbilical cord after delivery, right, what happened? Remember, our body response to injury is inflammation. So inflammation is supposed to happen, and that inflammation is what is going to allow the umbilical cord to separate. But if you cut it and inflammation does not occur, then that will lead to delay in umbilical cord separation. And then when you look at the site of where the bacteria is, down to the absence of pus formation, because neutrophil cannot get to that site. And of course, because all the neutrophil, they can't adhere to the wall, they are all in circulation, then that will lead to what? Neutrophilia in those patients. Very good. And then, like I mentioned earlier, corticosteroid, catecholamine, they inhibit what? Adhesion molecule. So by inhibiting adhesion molecule, that means the normal marginating pool will become what? Circulating pool. And that will lead to increase in peripheral neutrophil count because of demargination. So they're going to have neutrophilic leukocytosis. And that's why if somebody is having things like seizure, right? So with seizure, remember it's a form of catecholamines, right? So a lot of catecholamine will be released. So that's why when those patients come in, they could have neutrophilic leukocytosis. That doesn't mean that they have infection. It's just because of what? Of those demargination. Same thing if somebody is on corticosteroid, they could also have neutrophilic leukocytosis. That doesn't mean that they have what? Active infection. It's just because of what? Demargination. And one of the things that to look for, you can look for immature neutrophil like what? Like bands. So if there's no bands, that means this is likely what? Demargination is not infection. So now let's say tight binding was okay. The neutrophil was able to bind to the wall. So what will be the next step? So the next step is going to be what? Migration. So the neutrophil has to migrate out in between the what? Endothelial cell. So the next step is going to be migration. And that migration is also referred to as what? That transmigration is also referred to as diapedesis. So the next step there is going to be neutrophil transmigration. And that neutrophil transmigration is also what we call diapedesis. So that will be the next step. So the process by which neutrophils squeeze through the endothelial cell into the tissue during acute inflammation. And what are the mechanisms? So neutrophil moving along the venular endothelial cell dissolve the venular basement membrane, and it's going to release type 4 collagenase. It's going to use that collagenase to be able to dissolve those basement membrane. Exposed by previous histamine-mediated endothelial contraction. Remember, I mentioned the endothelial contraction that's been done by histamine in the vascular changes, and enter the interstitial tissue. And of course, as they go into the interstitial tissue, what's going with them? Very good. So plasma-derived fluid rich in protein and cell, which is what we call exudates, is also going to accumulate in the interstitial tissue. And remember, in this protein, what I think I'm going to have, one of the things we're going to have there is our what? Opsinin. Very good. Example like our IgG and C3b are also going to be present in those fluid. And then what mediates this transmigration? So this transmigration is mediated by platelets, endothelial cell adhesion molecule 1, and which is PECAM1. So that's what's going to be present on the neutrophil, and that's also what's present on the endothelial cell. And the CD marker for that is CD31. So CD31 for both of them. So what's the function of this exudate? So it dilutes bacterial toxin if they are present. And then remember, like I mentioned, they contain what? Opsinin. Because opsinin is important to coat the bacteria so that it can facilitate phagocytosis. And what are those opsinin? So IgG and C3b, right? Remember, our C3b is from the complement system. So that's one of the products from the complement. So now, after transmigration, so now they out of the what? Now they are out of the blood vessel. So now we have our white blood cell out of the blood vessel. So now they need to move to where the bacteria is. And that process is what we call migration. So they need to migrate to where those bacteria are located. And that migration is guided by what we call, that's also referred to as neutrophil chemotaxis. So the definition, so directed migration of neutrophils towards the site of infection or injury along a chemical gradient. And the mechanism, so the neutrophils follow a chemical gradient that lead to the infection site. And this is chemotactic mediators bind to the neutrophil receptor. And then once those chemotactic binds to the neutrophil receptor, they facilitate the movement of that neutrophil towards the site of the injury or the bacteria. So what are these endogenous mediators that are involved in this process? And this, we have a great mnemonic to be able to remember them. So that's our click PN. So click PN. So what does C stand for? So C is C5A from complement system. L is LTB4 from lipo-oxygenase pathway. I is interleukin 8, which is a part of chemokine. K is kallikrein from kallikrein kinase system. P is platelet activating factor, which is produced from neutrophil, platelets, endothelial cell, mast cell, and monocyte. And the last one there is exogenous, the exogenous source, which is going to be the bacteria product, which is N-formylmethionine peptide. So these are all our neutrophil what? Chemotaxis. So the first, the few one there, the C5A, LTB4, interleukin 8, kallikrein, platelet activating factor, those one they are what? Endogenous mediator. Whereby the last one, which is our N, which is N-formylmethionine peptide, that's from the bacteria products. And this chemotactic agent, they bind to the GPCR, which is G protein coupled receptor on the leukocyte. And the binding causes the release of calcium, and that increased neutrophil motility, guys, so that the neutrophil could move towards the site of the injury or where the 6-year-old girl has recurrent bacterial infection. And then look at there's absence of pus, so there's no pus, even though despite the bacterial infection, there's no pus at the site of the infection. And when we do a lab, there is a persistent neutrophilia. So this tells me that there's a problem with what? This patient likely have what? Leukocyte adhesion deficiency. So which step of leukocyte extravasation is most likely defective? So down to the what? Farm adhesion. So this is a problem with adhesion deficiency. Remember, there are two of them. We have the adhesion deficiency type 2, which is due to defect in what? S. Lewis. And we also have type 1, which is problem with integrin. Very good. Next, a neutrophil exits a host capillary venous by squeezing between the endothelial cell. Which molecule primarily responsible for this process? Remember, that molecule is what? Our PECAM1, which is CD31. And this is present on both the endothelial cell and the leukocyte. Very good. Next one. Which mediator is most important for directing leukocyte to the sites of tissue injury after they exit the blood vessel? So they're asking us for what? Our neutrophil chemotaxis, guys. So remember C5a, LTB4, interleukin 8, kallikrein, platelet activating factor, and N-methyl, right, peptide. So the best answer there will be what? Will be interleukin 8, which is D. Next one, in acute inflammation, leukocytes primarily exit the circulation at which location, right? Remember we said post capillary venous. That's where they go to exit. Next question, a 2-week-old newborn is evaluated for inflammation of the umbilical cord, which is omphalitis. The umbilical stump has not yet separated. The infant has a history of recurrent skin infections with Staphylococcus aureus, but no purulent discharge is noted. Lab study review markedly elevated neutrophil counts. Which of the following cellular defect is most likely cause this condition? So delay in separation of umbilical cord or inflammation of the umbilical cord with recurrent staph infection. And now we've seen there's no pus at the site of the infection, and we see a lot of increase in neutrophil in the circulation. So we see neutrophilia. So this is most likely what? Problem with integrin, guys, on the leukocyte. So the best answer there would be what? C. So this patient likely have leukocyte adhesion deficiency. And the last question there, which laboratory finding is most characteristic of leukocyte adhesion deficiency type 1? So like we mentioned, they're not going to have marginating pools of neutrophil. All their neutrophil are going to be what? Circulating, and that will lead to what? Neutrophilia.